Hello, everyone. It is July, and July is the month that we practice our Code Blue. Code Blue is an exhilarating experience. It can be absolutely terrifying if you haven't been through it or you don't know what you're doing. That's okay. This is why we practice. I've been here in the Care Center for several years, and I've participated in two Code Blues. One individual, I actually found her deceased, and we started the Code Blue process. And I was wearing one of those watches that Heidi had for her sleep program. Really expensive watch, couple $1,000s. It was, tracking heart rate, metabolic rate, your steps, everything. And when it was all said and done, it was off the charts. You couldn't even get it that high running several miles. And it's just the sheer adrenaline rush that I felt. Although it was terrifying, being I have taken CPR classes, being I had been through a code before, it just kind of fell into place. The succinct steps that we needed to take fell into place. And I think the same thing would happen for you guys if you haven't been through a Code Blue. I just want to go over some basic things with the Code Blue, kind of how it's changed in the last few years and how you should respond. When you walk into a room and find someone deceased, clinically, not biologically, clinically, so their heart is not beating, they're not breathing, the first thing you need to do is get help. And there's nothing wrong with poking your head outside the door and yelling at the top of your lungs, Code Blue, I need help, okay? The receptionist, the HUC, should be able to call a Code Blue. Anyone can call a Code Blue by dialing 22224 and speaking to the operator. At that point, you want to get people in the room, but you as the person that found the resident or patient coded, it is your job to start the delegating process so everyone else gets what they need. We need the AED. We need the gurney. We need the crash cart because we need a backboard. We need to have a patent airway. And we need assistance. We can't just do a code with two people. We need multiple people. We need to be able to switch off. There are various needs that are going to come up during a code. Someone should probably get a blood sugar. Just some very basic tests to make sure that the reason for the code isn't simple. Ultimately, the hospital is going to come to us and we kind of meet them in the middle. We do a pass off. We can't just pass the resident off to the ER and call it a day. Someone absolutely has to go down there and give report. The doctor's going to want a good, thorough history of what happened during the day, what's the diagnosis, has the resident been acting differently. You might want to pull some nursing notes, some orders, everything that's been administered that day, print it off, get it down there. I can't emphasize enough how important it is to be careful when you call a family member when a code is occurring. The last thing you want is to call someone who is very, very close to their mother or father and say, hey, mom's coding, get down here now. Someone might get into an accident. Someone might get hurt. We have to be able to relay to the family that there is an emergency. Can you come down here right now? And the best way to say is, hey, we're having a medical emergency with your mother. We need you to be here. Could you come right now? The answer might be yes, and then hang up. I wouldn't say mom is dying, mom has coded. The verbiage should be get here now. And sometimes that's not realistic. Some people might live hours away, and we'll just talk it through over the phone. But the goal is to get them here, and then the hospital's goal is to call them up, speak to the family members during the code, kind of know more detail as to what the resident's wishes are, and then ultimately determine when to stop the code if we can't revive them. I want you guys to keep in mind that for this particular population, the odds of running a successful code and bringing the person back are very, very slim. People have multiple comorbidities that play into stuff. I mean, you got diabetes, you might have multiple heart stents, you might have heart failure, COPD, all those things that that build throughout your life contribute to an unsuccessful code. I was told once that most people in our population probably have a 1 in 20 chance of actually being brought back. And if they are successfully brought back, that's great. But what are the odds that they're going to code again or wake up in the hospital, be in extreme pain, or be on life support? I mean, if you talk to most people, they'll say, hey, yeah, bring me back, but I don't want to be a vegetable. Well, guess what? That can't be guaranteed, okay? This is why we have to have those talks about code status. Also think about the individuals that come in here that do want to be full code. You know, when you've been through a code or two, you're able to describe what that's like, and they can decide for themselves whether or not it's worth it. Consider someone that's younger, like my age, 30. The chance of bringing someone like me back after a code is pretty good. I don't have multiple comorbidities. I don't have heart problems. I don't have asthma. I'm on very few medications. Nevertheless, it's a traumatizing experience. So let me tell you, we run the code, everyone responds, we get the person on the gurney, we might have some time to attempt a few shocks if necessary. We'll do the chest compressions, we'll push air into the airway, but our ultimate goal is to get the person to the emergency room as fast as we possibly can. In the emergency room, they have diagnostic equipment, they have more people, they have more room. They have more room compared to the little rooms that we have. They can do so much more. Lab can respond faster as well. Everything just kind of flows because an emergency room is meant for a code. A nursing home just isn't meant for a code. So a couple of years back, the care center would start the code, the code would then be finished. If a person were to pass away in an emergency room, any emergency room, they wouldn't come back to the care center after death. The hospital does have to count that as a death on their part, and they do have to send the person to the morgue. So if family does come to see the body to mourn, they do unfortunately have to go to the emergency room for that. Now, when they go to the ER, they might still have a big tube down their throat. Intubation, establishing that airway is a really big part of running a successful code. You got to have air. That might still be in there. Any medical devices will probably still be in there. If they were unable to get quick IV access, they might just jam one into the leg, into the bone. All that stuff might be there. It could be traumatic. It might just be smart to prep the family. Now, in the era of COVID, the Code Blue has taken a bit of a twist. A Code Blue is considered an aerosolizing generated procedure, kind of like suctioning. If we think a person has COVID, or if a person does have COVID and they code, we should not just be entering the room and doing CPR. We should have an N95 on. We should take one of those big bath tarps that you would put over your bathtub, and that should be over the resident while we're pushing air in to prevent those aerosolized particles from pushing out at us. That is just one of the modifications. Someday we will get through this COVID and we won't have to worry about that, but for now it is just standard practice. So what are we going to do today? We're going to have a situation. I have a mannequin. We're going to say his name is Kevin. Kevin came from the hospital after a heart transplant, and he was one of those fellas that had an LVAD in. It's one of those devices that you jam into the left ventricle, and it basically helps to pump your heart in the event where you have heart failure. So Kevin is 45 years old. He's younger than most. He's not ready to die. He just got a new heart. He's excited. And today we find him in the dining room, coded. He's not breathing. His heart's not beating. He's just sitting back in his wheelchair. And let's take a look at how staff respond. I used to have a debate with one of my DONs about whether or not we should use the lift to get someone from the wheelchair to the floor. I have spoken to several people about this, and the consensus is that when a life is in immediate jeopardy, your obligation is to save it. You should be, if safe and if you feel comfortable, be able to pull that person from the wheelchair to the floor to start compressions. Time is of the essence. Do not wait. If you do not feel comfortable pulling the person to the floor because you're weaker, you feel you might get hurt, don't hurt yourself. But if you're like me and you feel comfortable pulling someone to the floor, do it. We want to do whatever we need to do to save a life and to respect the wishes of the resident. So with that said, let's set up my secret cam in the dining room, run this code, see how it plays out, and then we will debrief after this by video. All right, here we go. All right, guys, Chrissy's gonna rock this.
Oh man, are you okay? Are you okay? Can you respond? No? Want me to call 911? Anybody? I got four girls and,
Are we actually calling 911?
no.
Okay. So it's not being announced. Yeah.
All right, good timing.
I need somebody about the transfer that you need. You need to probably get him on the floor if I can get some help.
Yep.
All right, let's look.
Carefully pull to the floor. Yeah, he's diabetic. That happens. Yep, you just start those good compressions, don't stop.
You don't want me to rip all this open, do you?
We will replace it.
Attention. Medical alert. Cold blue drill. Care center dining room. Cold blue drill. Care center dining room.
Check responsiveness. Call for help.
Remember, we want to take the clothes off of the patient.
Attach deferred pads to patient's bare chest.
You're gonna replace all this, all right?
Absolutely. All right, the journey's coming. Good, the teamwork. People
Attach
are
deferred
moving
pads
things
to
away.
patient's bare chest.
Beautiful. How well can we lower that?
I know.
Carol, do you want to be
Attach deferred pads to patient's bare chest.
Just want to document all that stuff. Okay, so
Attach deferred pads to patient's bare chest.
we need to think mouth, so someone needs to start ambulating.
Oh, I'm stiffer than us today.
Attach deferred pads to patient's bare chest.
So remember, it's not going to sense a big disease in the system.
Attach deferred pads to patient's bare chest.
And let's start the rotation here. Okay. And as you guys
Somebody
follow.
already called?
Yep. So
Okay,
as
just
you
making sure.
guys push through this, someone should get that gurney lowered. Good. Do we have a scoop? Okay, grab the scoop. We'll definitely want that. 30 and 2. 30 and 2.
Continue CPR. Push harder.
And after this round, you guys can certainly switch off. We don't need a backboard. He's on the floor.
Continue
So the
CPR.
situation, his name is Kevin. He came from the hospital. He had a heart transplant. He had an LVAD for 45 days, got a heart transplant today. He called.
Continue
He's
CPR.
45. He does not want to die. Okay, so at this point in time, likely the hospital would be here and they would be attaching the Lucas. But let's stop where we're at. We want to load them up and just get out of here.
Yeah. Each one of these
And
things, what-
we can roll them and put them on.
There you go.
Oh, take that one.
And this too. This along as well.
Now, as we go to the ER, if they're here, we don't have to worry. We'll still do chest compressions unless they hurt. Okay. I'm gonna pause now. We'll debrief.
We would still be doing the ambulance.